Hello, everybody. It's my pleasure to talk to you today about updates in medical management of Cushing syndrome, and we'll focus on the recent consensus Pituitary Society guidelines. I'm Maria Fleseriu from Oregon Health and Science University in Portland, Oregon, and it's my pleasure to have with me for discussion my co-chair from the Pituitary Society Consensus Guidelines, a friend and a colleague, Professor Beverly from Harvard Medical School and Massachusetts General Hospital. Thank you, Beverly.
Great to see you. And it's always fun to talk about the guidelines.
And these are my disclosures for the last 2 years. I was PI and with research funding to OHSU and from HRA Pharma, Recordati, Xeris, and Sparrow, occasional scientific consulting fee. So when we're talking about treatment of Cushing's, what are the goals? And sometimes they're a moving target and not easy to do all of them. Normalization of biochemical changes with minimal morbidity, easier said than done. Reversal of clinical features with quality of life improvement. And then long-term control without recurrence that, as you've heard earlier, it's not as good as we used to think. Many patients will recur. This is a complex algorithm, and I'm going to show you more details, but just to see that for patients with Cushing's, we have to focus first on what's the main treatment, and if they have Cushing's disease, rarely they need preoperative medical therapy, especially in US, it's not used very frequently. We discussed at the guidelines that in other countries it's used more, but pituitary surgery remains first line of treatment. However, many patients will not be in remission, even in expert center. The numbers for microadenoma go to 80–90%, but for macroadenoma, it's even less. So overall, what we have recommended and suggested, and this is not new, but it's sometimes not done. Patients with Cushing's disease need to have surgery in Pituitary Center of Excellence, done by an experienced surgeon, and then followed by a multidisciplinary team. And what we have also recommended that we don't have enough is the outcomes of pituitary surgery, in addition to the cost effectiveness, should be reported for all these centers. Now, what happens if the patient is not in remission? So if they have persistent disease, then we have to go back, and I'm not going to talk too much in detail today, is we have to go back to the drawing board and decide if the patient has Cushing's. So if the histology is negative, then we step back and think what's going on. But then if the patient has persistent disease that's confirmed, then main treatment would be medical therapy. And sometimes we also use other treatments as radiation, for example, and then we follow the patient. However, reoperation, especially for patients with histology positive, it's also an option. The repeat surgery is potentially curative, but doesn't work in all the cases. It's clearly lower in about 50%, and with addition of hypopituitarism also in about half of the patients. So I tell the patients that yes, you have a chances of remission, and then patient preference is very, very important for that. So looking at what's next, repeat surgery or medical therapy, we have now several drugs available, and you see here on the list based on where they work. Not all of them are FDA approved, and I will mention which one are on label and which one are off label. We have neuromodulators of ACTH release that we'll talk later about them. We have adrenal steroidogenesis inhibitors, and we have glucocorticoid receptor blocker. Each of them work in different ways. And also sometimes we use combination. So let's focus from the adrenal steroidogenesis inhibitor that are now the mainstay of therapy. We had 2 recently approved. Levoketoconazole is the one that's the most recent approved. It's an orally administered ketoconazole stereoisomer, and it's a very potent steroidogenesis inhibitor. Now, keep in mind that ketoconazole is a racemic mixture of 2 enantiomers. and it's an azole antifungal drug approved for treatment of endogenous Cushing's in Europe and used off-label in the United States. Now, the main study that we had with levokitoconazole was SONIX. It was a phase 3, multi-center, open-label, non-randomized, single-arm study. So if you're hearing me detailing all these type of studies, this is very important because how we look at the result, and also it's important because sometimes we can compare the direct numbers because the studies are so different. This study, for example, looked at the mean 24-hour urinary free cortisol of at least 1.5 times upper limit of normal. And the primary outcome was also different compared with other studies. There was proportion of patients with normalization at the end of maintenance without dose increase during that maintenance. So in this study, 31% were responders. And if you look at the MUFC normalization overall, patients had very high urinary free cortisol and then significantly decreased by 1 month and then hover around the normal, and 31% responded overall. If we look at clinical features in that study, published later, not just in the main paper, acne, hirsutism, and peripheral edema improved. And if we're looking for clinical signs and symptoms, and you've seen even a diagnosis, sometimes some patients have more features than others, and it's not always correlated with how high the urine is. Furthermore, with treatment, as you can see in green is no change, in orange is worsening. Some of the patients in blue here will improve overall, but some patients wouldn't change. And this is really related with where they started at baseline. If we look at the quality of life questionnaire, patients improved overall in the study with this drug. So moving on, for levokitoconazole, another study, Logix, this time was a phase 3 double-blind, placebo-controlled, randomized withdrawal studies. Also, the UFC was at least 1.5 times upper limit of normal. And keep in mind that if the higher they start patients, the rates of control could be changed when we look at that. The primary outcome in this study that had a placebo was proportion of patients with loss of UFC response during randomized withdrawal phase. So if we're looking briefly, what happened with the patients, there were 84 patients enrolled. Few of them came from the previous study I shown you. They were treated with levokitoconazole, and then 44 patients that were normal randomized in an intent to treat. Some of them treated with levokitoconazole, some with placebo. And then patients after that entered and completed the restoration phase or levokitoconazole. So let's look at the results. Keep in mind, the primary endpoint was loss of therapeutic response. So you can see here, this was the loss of therapeutic response with levokitoconazole, and look at with placebo. And then if we look at normalization, that was a secondary endpoint. If we're thinking the first study was UFC was primary endpoint, was 50% with levokitoconazole versus 4.5 with placebo. Looking at the adverse events, and I'm going to show you for all the studies, there are AEs in general, that some of them are drug-related, as you can see here in 40% of cases. Few of them are serious. What's important to look for all the studies are the most common AEs. And also, in my view, I look the one that possibly are related to adrenal insufficiency, and nausea sometimes could be withdrawal, could be adrenal insufficiency, was seen in a lot of patients, same with hypertension and headaches. For levokitoconazole, the study had specific AEs of special interest, and liver-related in these studies were almost 11%, QT prolongation almost 11%, and adrenal insufficiency almost 10%. So in general, based on the studies and on clinical practice, though the drug is recently approved, we need to obtain baseline liver test and EKG and correct hypokalemia and hypomagnesemia before starting the drug. I usually start at the recommended dose twice a day and then slowly titrating. And you'll see that This is basically for all the drug. Titrate on based on cortisol changes when we can measure, individual tolerability, improvement in signs and symptoms, and also where we start, going to maximum dose 60 milligrams twice a day, and the drug has drug-drug interactions that we have to look for. Now, levokitoconazole has an FDA warning for LFTs elevation and QTc prolongation. So we need to perform EKG in all patients, as I mentioned earlier, but also to use with caution if risk factors for QT prolongation. And keep in mind that patients with Cushing's are more prone to increase QT. So this is very important to look at in detail, monitor closely for adrenal insufficiency. And usually if I think it's either withdrawal or adrenal insufficiency, I decrease the dose and sometimes even stop as needed. Let's switch gears and talk about another adrenal steroidogenesis inhibitors. This time, it's an oral inhibitor of 11 beta hydroxylase, but also it's inhibiting aldosterone synthase. So there were several studies over the years, I'm not going to show you all of them, that shown results with this drug. And phase 3, Link 3, was a prospective multi-center open label with a double-blind randomized withdrawal period. So it had 4 steps. And again, this is very important when we look at numbers and even attempt to try to compare. But the primary objective for the study was to compare response at the end of period 3, so the randomization versus placebo. And the complete response with drug versus placebo at week 34 was 86% for the drug and 10% versus placebo. And at week 24, overall, 72 out of 137 patients maintained a complete response without up titration. So you'll see that the numbers differ even for the same drug from study to study. So these patients had some, this study had some patients that also had radiation. And if you look here on the left, the differences were not very high if it was history of radiation between osilodostatin and placebo. And also based on doses, this is less than 5 and more than 5. The radiation did not play a huge role. How about adverse events? This is osilodostatin versus placebo. As you can see, for looking at all the AEs, were 72 for the drug, also very high with placebo, 66. Keep in mind, these were patients with Cushing, so we expect to have adverse events. However, we really need to look at the details. These were adverse events requiring dose adjustment. That was 19% for the drug, 14% versus placebo. And then the most common study emergent adverse events were several that we need to notice: nausea, anemia, arthralgia, headache, asthenia. So we really have to look into, is this again adrenal insufficiency versus withdrawal overall? The next study, and the most recent one published this year, was a phase 3 multi-center trial. This time the placebo was at the beginning. So it was 12-week randomized, double-blind placebo-controlled, osilodostatin to placebo 2:1, and then everybody got on treatment, open label. I wanted to point out that the UFCs were lower at baseline. It was 1.3, and the primary endpoint was proportion of randomized patients with normal UFC at week 12. And if we're looking now, overall, this is percentage of patients that are controlled from week 1, week 2, week 5, week 12. So clearly increased significantly and almost reached 80% at week 12. How about the AEs? The placebo control period and overall period have different types of AEs. I wanted you to focus just the overall period. So all patients had almost half of them had decreased appetite, arthralgia. Several of them had fatigue, nausea, headache, myalgias, were getting to 26% dizziness, and then adrenal insufficiency per se, 24%. Doesn't mean that this was just the rate of adrenal insufficiency for this drug, because all of these symptoms potentially could have been adrenal insufficiency and not just withdrawal. But for all the studies, when we look at the AEs, is how they are reported by the primary investigators. So in clinical practice, we should really look at this and watch for and ask the patients. The most recent study that we have contributed to, both me and Dr. Biller, was the LINX-3 study extension. This has been recently published. And this is the data I've shown you earlier. This is the mean UFC with average osilodostatin dose for the main study. And then the patients continued in extension. And as you can see, the UFC will remain normal for a large proportion of patients, and they were not on a very high dose overall, hovering around 5-6, and improvements in cardiovascular, metabolic-related parameters, physical manifestation, and quality of life also improved. So we have now long-term data showing that patients could be, it's true, over time the numbers are decreasing, could be longer-term controlled on adrenal steroidogenesis inhibitors. For osilodostatin, it's important also to correct the hypokalemia and hypomagnesemia and obtain baseline EKG prior to starting. To initiate, the recommended one, it's 2 milligram orally BID. We titrate very, very slow and no more frequently than 2 weeks based on the same things you heard earlier. Maximum recommended dosage is 30 milligram twice daily, and drug-drug interaction. Closely monitoring for adrenal insufficiency. This is a potent drug. Dosage reduction or interruption may be necessary. And again, we have to watch for QTC prolongation and also elevation because the mechanism is different in adrenal hormonal precursors and androgen, monitor for hypokalemia. Worsening of hypertension was rare overall, but in some patients, edema and hirsutism. There are, as I mentioned earlier, several other adrenal steroidogenesis inhibitors that are off-label in US. We have used them for many, many years. Ketoconazole is one of them, also metirapone that was on and off available. Mitotane, that's mostly beneficial in adrenal cancer, rarely used in US otherwise. And etomidate, that's the only intravenous adrenal steroidogenesis inhibitor or medication for Cushing's available for that matter. So it has a very rapid action, and for few patients a year, we have to use it with intensive ICU monitoring, but it decreases the cortisol very well. So now that we have discussed about all the adrenal steroidogenesis inhibitors, I have a question for you, Beverly. In real life, how do you use the most recent approved adrenal steroidogenesis inhibitors, osilodostatin and levoketoconazole, which is the dose you use and how you titrate?
Yeah, that's a great question. And I'll just start by saying how wonderful it is that we now have several new medicines from which to choose, which is obviously very beneficial for our patients because we can individualize the therapy. Levoketoconazole is the one that's most recently approved. And so we're just starting to use it, but therefore we are using the prescribed dose, which is 150 milligrams twice daily. The osilodostatin has been around a little bit longer because it was approved a bit earlier. And there the approved starting dose is 2 milligrams twice daily. I must say that I often give a lower dose than that of 1 milligram twice a day because unless we're in a rush with a patient who has severe Cushing's, we find that patients tolerate the gradual up titration better, and perhaps there will be a lower rate of adrenal insufficiency.
Thank you, Beverly. And talking about the severe hypercortisolism, when do you use block and replace? Can you describe for the clinicians that are watching us?
Yeah, so I'll just mention first that, as you know, at the consensus meeting, that was a topic that was quite controversial because there are people who never use block and replace. There are people who pretty much always use block and replace, and then probably most of us fall somewhere in the middle. I'm towards the end of not using it too often, mainly because when we replace after blocking cortisol production, I think we overdo it sometimes. And so we ourselves are creating iatrogenic Cushing's, but it can be very valuable when someone is seriously ill and perhaps, developing sepsis and hospitalized. you really want rapid control of the cortisol. So you can give high doses of adrenal blocking drugs and then give back some glucocorticoids. That's when I tend to think about using it.
Great, thank you. Let's switch gears now and talk about drugs for Cushing's disease. These are not for all patients with Cushing syndrome that work at the pituitary level. So we have pasireotide, that's a somatostatin receptor ligand, FDA approved, works rapidly. Control rate is approximately 50% in mild Cushing's disease. And that's how when I'm thinking to use it. Otherwise, the main studies that I'm not going to show you today showed response rate at about 20% for all comers, improves clinical signs and symptoms, induces tumor shrinkage, and also for rare patients that have pituitary macroadenomas, this is the drug that I'm thinking first. Considerations, side effects, GI disturbances, nausea, cholelithiasis as all the somatostatin receptor ligand. However, in addition to others, hyperglycemia is very frequent, 60 to 70% of patients in all the studies and in my clinical practice. So we really have to watch for blood glucose level. What was interesting for this study, and looking forward to see even more data, was the clinical improvements were significantly higher for patients that had normal urine and normal salivary cortisol. You don't even have to look at all the details of this particular slide. Look just the blue. Controlled were very few patients, but these patients were the ones that had better systolic blood pressure, better diastolic blood pressure, and better weight. So maybe the studies had urinary free cortisol as endpoint, so it's hard to look in more details than here, but maybe we need to look at other markers of what we define as biochemical control. Also, cabergoline could be used for Cushing's disease, not for other patients with Cushing syndrome. The meta-analysis that, it's as good as the studies that could be included was about 30% of patients. However, this is not a drug that works for everybody. We know now that there are more impulse control disorders, higher rates than we used to think, from hypersexuality with pathological gambling. And we have to use higher doses to actually control the Cushing's. So I use it mostly for combinations, but I rarely use it for patients with Cushing's disease as monotherapy. Now, the third mechanism of action is blocking the glucocorticoid receptor blocker. Again, we go back for all patients with Cushing syndrome, so we're not just at the Cushing's disease. The drug is approved to treat hyperglycemia in adults with endogenous Cushing syndrome based on the phase 3 trial called Seismic, where we had 50 patients in doses between 300 and 1200. The large majority were on 900, improved significantly the glucose, even with decreasing in insulin and clinical signs and symptoms. Considerations, adrenal insufficiency, moderate to severe hypokalemia. We can measure cortisol because this is blocking the glucocorticoid receptor. So we need to base all the decision on clinical parameters, and also the thyroid function needs close monitoring. So as a brief summary of all the medical therapies that I have shown you, if you're thinking, oh, there are so many now that are approved, when should we use one versus the other? That really depends. And we have discussed in the guidelines and also clearly a lot in the discussion in the consensus meeting. That really depends also on countries, on availability, and on cost of the drugs. But in general, if we want rapid normalization, adrenal steroidogenesis inhibitor is recommended. Oral oscillostat or metirapone versus intravenous etomidate for rapid normalization. I wanted to point out that at the time of the consensus meeting, levokitoconazole was not approved. For Cushing's disease, as I mentioned earlier, if it's residual tumor present, pasireotide or cabergoline, so drugs that work at the pituitary level are preferred first, if they work. If not, we have to control the cortisol. If the patient has history of bipolar or impulse control disorder, I will definitely consider avoiding cabergoline. And then Ketoconazole or levoketoconazole might be favored for ease of dose titration. Concerns about inducing hepatotoxicity and the need for monitor liver enzymes can lead to underdosing. So we really have to look at efficacy based on the patient being up titrated properly. If the patient is pregnant or potential for pregnancy, was a lot of discussion. Of course, nothing is approved. None of them can be used, but there are some cases on cabergoline or metirapone published. And then drug intolerance or side effects and concomitant comorbidities present should also guide the medication choice. And we have spent a lot of time, and really this goes to, it has to be individualized treatment. Combination therapies, I'm not going to go in a lot of details, just for you to know that they exist. Which one we should start first, what dose. There were very few studies looking at this in detail and very few prospective, and several of them just presented, not even published. But definitely this is something that we should look in more detail, because it's possible with lower doses of two medications, if there are no adverse events, we're able to control more patients. So I have reviewed for you now several of the medication, when to use it, and what we have discussed in the guidelines about factors to consider one versus the other. But we didn't talk about other treatments besides the repeat surgery and the medication. When do you use other treatments, and where do they fit in the treatment algorithm?
Yeah, so before we had all of these wonderful medicines from which we can choose, of course, we only had the options of repeat pituitary surgery, the oldest treatment, removing both adrenals, or giving radiation while also treating with medicine. And so if we think about those, the repeat transphenodal surgery can be a good solution if done by an expert pituitary surgeon, although the remission rates are lower than initially, and the risk of hypopituitarism is higher than at the first operation. Nevertheless, that can be a good choice for some patients. When we think about bilateral adrenalectomy, that is the treatment that was used in the 50s and 60s, and it has the advantage of immediately providing remission because there's no production of cortisol if the adrenals are gone, and it's usually permanent. It's well tolerated if it's done laparoscopically. It has more risks because potentially it's abdominal surgery. Sometimes it needs to be converted to open if there are complications. Those patients need both lifelong mineralocorticoids and glucocorticoids, and that can have some issues as well. But what we really worry about in those patients is the long-term risk of the tumor that's not been treated in pituitary Cushing's progressing, formerly called Nelson syndrome. Now we tend to call it corticotroph tumor progression. And so those are things we worry about. But as we discussed at the consensus meeting, this really now is considered a last resort in most patients. The exception being that some people feel it's a good choice in women who may want to achieve fertility. And it also is a good choice if someone can't be controlled even with combinations of medications, although I think that's less likely nowadays. Just to finish up, I'll mention radiation. Radiation delivered to the pituitary gland is also well tolerated, especially if we use stereotactic radiosurgery, and affords tumor control in most patients. It doesn't do quite as well in terms of cortisol control. And of course, when we give radiation, we have to be giving medication at the same time, because radiation has the disadvantage of taking years to work, sometimes a year or two, sometimes much longer than that, and has the risk of developing pituitary deficiencies, potentially damaging nearby structures, and secondary neoplasia, with about a 1% rate of that at 10 years and a 2% rate at 20 years. So these patients need long-term scans to monitor for that. We also need periodically to withdraw the medication we're giving to see whether the radiation has taken effect. So the guidelines meeting that we participated in really saw this as something to use if there's a persistent tumor in an unresectable area in patients who couldn't be easily controlled, or an aggressive tumor. Is that when you would use it?
I agree. I think there are differences between countries and also the guidelines. we had several from experts from many other continents, not just from US. And I think it's very variable. I use it rarely unless it's a tumor that's growing, extremely rare, but pituitary microadenomas in Cushing's could be very aggressive, or if none of the medical therapies are working or the patient doesn't tolerate, but much, much more rare than other countries that don't have any of the medications. And then even 10 years later, for a chance of 50%, they will take it rather than not treat overall. And I completely agree. Thank you so much for this overview of all the other treatments, and hope you liked our discussion and you like the really intense overview of medications. And we are both, as you heard, very happy that from nothing FDA approved 10 years ago, now we have 4 medications that we can offer to our patients that are improving their symptoms, are improving their biochemical control, and we have data for long-term use right now. So I think we're not where we want to be to have perfectly individualized treatment, but we're really striving for excellence for care for patients with Cushing's. Thank you. So in conclusion, I've shown you this complicated treatment summary that we have reviewed almost line by line. And I really want to thank you for the attention and to highlight that the patients with Cushing syndrome and also with Cushing's disease need individualized treatment. And we have to make significant efforts to diagnose the patients earlier. Maybe if the disease is less serious, the outcomes will be better also. Thank you.